Hello, hello. Okay, everyone, so it is 7:05, so I'm going to go ahead and get us started. So welcome to the latest edition of Shy Hack Night Remote. This is Shy Hack Night number 415, which is crazy to think. But we are very glad that you're here to join us. My name is Ryan Spencer, and I'll be one of your co-hosts this evening, along with my other co-host.
My name is Miyako Furuhashi. I'll be your co-host.
Yeah, so we're excited to be hosting the Amulet Health team, so Adam Anderson and Nolan Winkler, from Amulet Health to talk about cancer volume data and why that matters for when choosing a hospital for surgery. We are also going to have a post live stream Zoom, so as well as a Q&A as well. So there will be some time afterwards, so after presentation, to ask the host, or the presenter, some questions, as well as a civic hacking portion evening for tonight. And so we will be taking the Q&A questions via our YouTube live chat. And of course, as a friendly reminder that we do still have a code of conduct. So although we're virtual, our code of conduct still applies. And so if you want to check that out, you can go to Shy Hack Night's website. But just remember to be respectful. These are our guests. We are all an inclusive environment. And so we want to make sure that everyone feels welcomed and can ask questions in a free manner. Anything else you would like to add, Miyako?
I think you covered well. Thank you.
So I guess with further ado, we can start with our announcements.
Okay, so we have a Slack. A lot of communication happens outside of the Chai Hack Night remote evening. Please join. The URL is slackme.chaihacknight.org. We have various topics covered, and you can ask questions, concerns, anything goes. Please join us in our Slack channel.
Okay, so upcoming presentation. So next week we will have H2 Now for Chicago Water Week, followed by El Ramel with Get Cities and Haru Koren, sorry if I mispronounced this name, and Mike Dumke of ProPublica to cover seniors dying in subsidized housing. So we do have some exciting topics coming up, so feel free to join us again these next few Tuesdays to hear some from some more great presentations.
And we do have a help desk. Go ahead.
Okay, yeah. So we do also have the Shy Hack Night help desk. So there is a tech and data help desk now. And so if you would like to get help from the help desk, or maybe you feel like you have some skills that you would like to volunteer, please feel free to follow the links and sign up. We are always looking for more people to help out. And of course, if you have any organizations that you know that are in need of help, this is a really great resource for them as well.
So we would like to know what's going on with your breakout group. Please fill out your breakout group status. The link is listed below.
And register to vote by mail. So if you choose to register to vote by mail this year, remember that the deadline is October 29th. So that's going to come up very quickly. You're going to blink and it's already going to be here. And so if you have not already done so, please follow these links. Tell your friends, your families, strangers on the street, people in the grocery store, make sure you are registered to vote, and encourage others to do the same if you choose to vote by mail this year.
Fill out your census and tell everybody you should too. Census is very important. This is how government decides where the money goes, who gets the money. Please fill out census. It's my2020census.gov. I already filled mine in April. Please be, Illinois is quite low. Please do.
Okay, and so remember there will be a post live stream Zoom call. So this is going to be a great time to do some intros, get to know each other a little bit more, as well as the breakout pitches, and of course the civic hacking portion of the evening. And so this is going to start shortly after this presentation ends. So around 8 p.m., follow this link. It will also be in the Shy Hack Night remote Slack channel as well. And yeah, come say hi to that. Okay, so I think that is it for that. And so Without further ado, let's go ahead and let our presenters, Adam Anderson and Nolan Winkler from Amulet Health, start the presentation.
Okay, thank you, Ryan and Mieko. I'm just going to share my screen here, bring up the slides. Oh, let me get out of here, go into presentation. Okay, I just want to confirm everyone can see that. Okay, great. Okay, so I'm Adam Anderson. I'm co-presenting with Nolan Winkler. We're going to be talking about Amulet Health. Just a little background about myself. I've been working in healthcare my whole career, and most of those years as a clinician, and more recently as a quality and safety professional. I'm going to go ahead and let Nolan introduce himself.
And hi, I'm Nolan. So currently I'm working as a data analyst for a healthcare research organization. And right before that, I was similarly a research assistant at Chicago Medicine. And for the 3 years after college, I was doing education in various capacities in Chicago schools after graduating from Chicago in 2016 with a math and CS degree.
All right, so we definitely want to thank Chi-Hacknight for having us present, and we'll get into it. So Amulet Health is best described as a patient advocacy website to support and provide resources to patient and families looking for more information about cancer surgery. Specifically, Amulet Health provides data about cancer surgery volumes from hospitals, as well as more resources about finding a second medical opinion. I will say that Amulet Health started as a breakout group at Chi-Hacknight, so we are very grateful to Chi-Hacknight and the community that supports it. So, as with all topics that are healthcare related, we do have a legal disclaimer. We are not cancer experts or physicians. This is not medical advice. We want you to consult with your physician about any medical issues or questions. And the views and opinions expressed are our own and not representative of our employers. I will just add that I did seek input from cancer surgeons for the site. So we weren't just sort of going into this completely blind. So before we share this site, we thought it would be good to give some background and context as to why and how we created the site. So why don't we start with the why? So why do cancer surgery volumes matter? Well, for one, there is substantial evidence showing that patients having a cancer surgery at a higher volume hospital are more likely to have a better outcome. And by outcome, we mean the likelihood of death 30 to 60 or 90 days after surgery, or the likelihood of having a lower rate of complications, and that would include things like blood clots and infections. The study I'm showing here was published in the Journal of the American Medical Association in 2019. It looked at 11 years worth of cancer surgery data from Medicare claims data, and there were over 500,000 patients in this data set, so this was a pretty robust data set. And this was one of their findings. The patients in the highest volume hospital, so that's the highest quintile, had a significantly lower 30-day mortality, that's the death rate, compared to the lowest volume hospitals, and that was in the lowest quintile. Other findings from this study showed a significantly lower rate of complications. So this, along with many other studies, and there are literally hundreds of these studies, that show that high volumes of high volume cancer surgery hospitals are essentially a predictor of a better outcome. So we have a pretty strong evidence base for this. In addition to the evidence, there is a lot of expert medical opinions that are essentially saying the same thing. These are 3 books that were published in the past 5 years, 2 by cancer surgeons, 1 by a plastic surgeon. And when they were giving sort of guidance about the factors you should put into how to decide on what surgeon to choose, they all said that the amount of the surgeries that a surgeon does should be strongly considered. So there's a lot of alignment with this, both in the evidence and with expert medical opinion. Now, the top author, Dr. Elisa Port, she's a breast cancer surgeon from New York. We thought her advice was like really well spoken. And what we did is we reached out to Dr. Port to see if we can get permission to share that advice on our website. And she did agree and give us permission to share her advice about choosing a cancer surgeon. So we are grateful for that. And I think this essentially kind of shows that there is a lot of strong evidence and medical opinion in support of using cancer surgery volumes as a variable to consider when deciding on a surgeon. And that evidence is so compelling that 2 states, Pennsylvania and California, have actually mandated that hospitals submit this data and share that data. And Nolan's going to talk more about that.
Thanks, Adam. So the obvious implication from some of Adam's comments is, of course, that patients having access to this cancer surgery volume data could be really useful in choosing their surgeon or in choosing the hospital they go to if they're going to be having a cancer surgery. So as Adam mentioned, Pennsylvania and California make this data publicly available at the hospital level, which is absolutely great. And also note that is 2 of 50 states. So this data is certainly not widely available. And while these 2 particular states are, we really commend them for publishing it, even the states that do publish it, the data is sometimes pretty hard to access and is not very patient friendly. So on these 2 websites that Pennsylvania and California have, which include their data sets, when going through them, if you're just kind of clicking through, you get to like the landing pages. Some of the data appears that it's only in PDF format on California's website, and you've got to click through a couple pages. It actually took a number of the members of our Chi-Hack Night breakout group like looking through this site for the first time to even find it. And also to get to these web pages in the first place, you really kind of have to know that this information is already available and exactly what to search for. Yeah, so just kind of getting the data that's already out there in and of itself isn't the easiest thing. And especially for patients, you're downloading a CSV that's not particularly friendly to you, even in the best case of the data that we do have. So next slide, Adam. Okay, so what we wanted to do, right, is make this cancer surgery volume data that we do have more accessible, more user-friendly, so that if a patient wanted to go and find it, they would be able to filter by, say, the county that they live in. We want to have it be sorted by volume so that they're seeing the top hospitals in terms of this metric, and have it be in browser. So once again, you don't have to go and download a CSV, pull it up in Excel, do all this sort of stuff yourself, especially when, if you're, say, an older patient, you might necessarily be the most technologically literate. So to go from this data that we had, and here's a little view of the PDF that Pennsylvania published, which, like I say, is kind of more front and center. The best that we could find, which is still a pretty good starting point, is we had some CSVs with the data being from California and from Pennsylvania. The 2 different states publish their data in different formats. So what that means in particular is that they have different units of analysis. So the level that the data is at, what each row corresponds to, was different. So we can see for Pennsylvania here on the left, we have 1 hospital in 1 year as a row, and then each of the columns is a cancer surgery volume for a different type. Whereas for California, what we had was that actually for each hospital, we would have a row for each different type of cancer surgery. So that meant that there would just be a single volume column as well as a column that said this type of surgery is, say, pancreatic. And then one more complication or thing that we had to deal with this data being differently formatted, coming from different places, is that there's a standard set of diagnosis codes that are used in the medical field called ICD 9 or 10 based on, they switched over in a recent year. So the data that we had One of them was from ICD 9 times. One of them was post the transition to ICD 10. So there's just some naming discrepancies that we had to resolve between the two data sets. So Adam, if you can go to the next slide. So what did we do at Shy Hack Night to try and change this? So the first thing that that I did was I thought that, okay, right, we're going to want a database. So I drew up an entity relationship diagram, designed a whole schema, started hosting it in Postgres, and then it just became very clear that that was overkill. So what I mean by that is the number of rows, the amount of data we have is just, really does not require that amount of complexity, which once again, I hope kind of hammers home that we need more data of this type. I would like for a database, something a little more powerful to be needed in order to host all the data we have, but we just don't have it. So what we did is we just wanted to create it into a nicely formatted data table. So as I mentioned, the Pennsylvania and California data were at different levels of analysis. So one thing we had to do was reshape the data to make sure that it was at the same level of analysis. So just based on what we thought was useful, we decided it would be one row would be a hospital in a given year with all of the different cancer surgery volumes as columns, as opposed to having many rows for each hospital corresponding to the different surgery types. So that was done using pandas and an IPython notebook. As you can see, we got a little import pandas up there in the top left. Another thing that we had to do is that Adam's subject matter expertise, really said that while we have a couple years of data, say 2015, 2016 for Pennsylvania, 2018 for California, what's most useful to patients is just to see the most recent years of data. So once again, if a patient goes to the website and they're seeing multiple rows for a given hospital, that's a little less intuitive, might be a little less user-friendly than just seeing one row for a given hospital. So to do that, I took over there, did some deduplication, which meant that I just wanted to choose the most recent year's data for each hospital. So there's actually the exact R code I used, a very short script. And finally, what we did is, because we thought that a database was overkill and to be able to host it very easily, was we just created a GitHub pages. We were already collaborating over GitHub, and Serge, who we'll mention later, who was a big contributor to this, found a nice framework for that, which is called Data Tables. It's a JavaScript plugin. And then Adam, if you could click on the little link in the bottom left, we'll show you kind of the first thing we came up with. And then can you zoom out a little bit?
That?
Yes.
Yeah. Is that good?
Yeah. Can you zoom out a little bit?
Zoom out. Let's see here.
Give me a control minus.
Is it zoomed in too much?
I think it's fine. So one thing you might notice here that we hopefully later improved on is it's a very wide data set. So when you go here right away, right, definitely a little zoom level would be better. But you can see that it's got one row per hospital. We made it so that we have the cancer surgeries each as a different column. And it just has the most recent data. So here, right, kind of the biggest thing if you're a patient, you don't want to look at all this data. Probably you only have one type of cancer. You're only going in for one type of cancer surgery. So that's kind of the first question we have right up there. So Adam, you could type in, say, I'm looking for bladder cancer surgery. And then all those other columns go away, and it's still showing the bladder cancer surgery volumes sorted by bladder cancer surgeries. So these are kind of like, if we're just using this one metric, these are the hospitals that we would say, are best or would recommend. Though, of course, right, this is just a correlation, as well as added some information about the National Cancer Institute designations. So what those are is that the National Cancer Institute is a specialty organization that has given a very small number of hospitals around the nation a little designation gold star saying this is a great hospital for cancer research, cancer surgeries, etc. So yeah, just with the kind of time we had at Tri-Hack Night, just focusing purely on the data, here was a kind of simple improvement that we thought we could make. So you can head back to the slides and go to the next one. But one thing you may have noticed is we still just have that California and Pennsylvania data, and we really want more data. So Adam's going to talk about ways we've tried to get that and some barriers we've run into.
Yeah, thanks, Nolan. We've certainly tried to get more data than just California and Pennsylvania. The one good thing about California and Pennsylvania, it includes all patients from all different payer groups. So it's a very comprehensive data set for those two states. There are other data sets available. One is Medicare claims data, which a lot of the research I talked about uses. However, this data is limited, or there's a barrier by a paywall. So the lowest price you could probably get this data is probably around $7,500, and that's if you're a research investigator. It's likely that you have to pay more as a as some sort of like innovator or something like that. So there's already a paywall to get Medicare claims data. And the other limitation with that data is that it only includes Medicare patients. So those over 65 or those that are disabled. So it's not necessarily covering all of the patients that have had cancer surgery. So besides that, there are national and state cancer registries that have this data reported to them. Again, that may not be comprehensive either, because sometimes that can be voluntary. Only certain hospitals are reporting that. But we figured, hey, we might as well try to reach out to the Illinois Cancer Registry, which is housed in IDPH. So with the help of Matt Chapman, we submitted a few FOIA requests. One was to IDPH, and we had all of the ICD-10 codes. We had everything we wanted because California and Pennsylvania already did that work. And IDPH's response was essentially that the information is considered confidential under an Illinois Health and Hazardous Substance Code. So for whatever reason, this information is private and confidential, and they could not share that with us. We also FOIA'd CMS because they have, all this claims data, and they did direct me to a data set that captures diagnosis groups, but that is not specific enough because it really doesn't capture all those specific cancer surgery procedure codes. So it was a step in the right direction, but still not good enough. So I think Nolan and I want to say that if anyone can assist with more information about appealing our requests or doing other kinds of requests, we're completely open to that, and we have our emails at the end. So that's kind of our journey. And again, special thanks to Matt Chapman for his help with that. So now a few other things I wanted to talk about. One is like many other health conditions, including most recently COVID-19, health disparities do exist with cancer survival. The findings from the study on the top there concluded that people of color have a lower 5-year survival across many different cancer types. Another study below that actually spoke to who receives complex cancer surgery at low-volume hospitals, and the findings of that study showed that people of color also are more likely to get their care for cancer surgery at a low-volume hospital. So there is some good that our site can provide for this issue, but I will say that a website will not address the structural racism and structural determinants of health that are likely contributing to a majority of these health disparities, and policy change and structural change are really needed to address that. And with cancer, a lot of the things can happen upstream, especially when it comes to prevention and screening and things like that. A few other things. You would think with the evidence about high volume hospitals having better outcomes, maybe there's a move towards centralizing cancer surgeries at those hospitals. That's something that has been talked about in the US. It is something that has happened in Canada and Western Europe, but those health systems are nationalized healthcare, so there's more public sort of structure there. So it's a little easier to do when you have public hospitals. In our country, we don't have a lot of different health systems that are publicly funded or publicly owned. So it's a little harder to do that, to consolidate into higher volume centers. Also, in rural parts of the United States, there might not be a high volume hospital anywhere near where those people live. So it's not the maybe easiest thing to pull off, but it does get talked about. So there is talk about that in the cancer community. Another issue is second medical opinions. There is a lot of evidence that people that have cancer are more likely to get a second medical opinion, and getting a second medical opinion can change your diagnosis, which could have a lasting effect on how you respond to that treatment. And last thing I'll share is with COVID-19, the amount of screening definitely decreased, especially during the height of the pandemic. So that's going to complicate cancer care even more and possibly delay diagnosis, so that there may be more need for cancer surgeries in the near future because screening was sort of impacted by this. So there's a lot of things to consider with this, but we hope that our website will provide some good resources for these issues. So without any further ado, I think we'll talk about more of the site. And these are the main contributors to the Amulet Health website. We want to thank each and every one of them for their contributions. And again, we all met at Chicago Hack Night, and it's all culminated into creating the site. Nolan, do you want to talk a little bit about the evolution?
Yeah, sure. So big thing here, projects change over time. So actually, before I joined the project, Adam had been working on trying to kind of come up with a score for hospitals, especially as a prototype right now, centered around Chicago, with cancer surgery volumes as kind of like one of the metrics. But in thinking this through, that's one kind of a hard problem that also doesn't necessarily get at the complexities of if you're a particular type of patient. So Adam realized, who really needs this data? Who is this most helpful for? People who are having, potentially life-threatening surgeries, have life-threatening conditions, could potentially benefit the most. So while, there was a good prototype of a very different type of website, we completely shifted by the time I had joined and ended up focusing on these cancer surgery volumes and trying to get these public and just get the idea that these are really important out to the public. So you can see that in the little bottom right there, this is kind of what we ended up with in terms of the accessibility and the user friendliness of the data that we had. And we're going to take you through the live version now.
All right. So I'll just kind of talk us through it, and Nolan, feel free to jump in. So this is our landing page. We kind of started off with talking about how access to a second medical opinion isn't always a guarantee, and there are only actually 7 states that actually protect the right for citizens to get a second medical opinion. And we have more about that on our second medical opinion page. So this is like just kind of general information for people seeking some information about second medical opinions. And then we kind of go through how do people find a second medical opinion with a cancer diagnosis. And usually what happens is when you kind of get diagnosed, usually through your primary doctor or oncologist, they're going to refer you to that cancer surgeon that's more likely going to be in their health system or in your network. But then after you get that opinion, and if you're interested in another opinion, there's just not a lot of resources out there to kind of guide you through that process. Navigating the health system with a cancer diagnosis is extremely challenging, and just thinking about getting a second medical opinion can be difficult in itself. So what we said is that, there is a lot of evidence that links the number of cancer surgeries a surgeon or hospital performs with better outcomes. So while it's important, it's not the only factor you should consider, but we are sort of just putting it out there for people to know, because I don't think a lot of people know that. And then we kind of get to like, how do you find information about cancer surgery volumes? So we talk about California and Pennsylvania publishing it, and other sites sharing something close to that. And then it's really more about like, hey, we want to get more of these volumes. We're actively working toward that. And if anyone is interested in helping us, we're more than willing to listen to that. So that's kind of our landing page. The next part is information about finding a second medical opinion for cancer surgery. And this is where we share Dr. Elisa Port's advice. So that kind of fits in nicely about, hey, if you're starting off and you really want to find a few other surgeons that could give you opinions, her advice about finding a cancer surgeon we thought was very helpful. And then we get into the NCI designation that Nolan discussed, that can be a gold star showing that they are probably doing a higher volume of cancer surgeries and doing the research, and there could be some evidence showing that they have better outcomes. So looking up an NCI hospital isn't a bad idea either. And then, of course, you have your California and Pennsylvania volumes data. And then, if for any hospital you look into, you should ask about volumes. I mean, there's nothing saying you can't ask. Maybe it's an uncomfortable question, but you can certainly ask the hospital. And I think the most common way people get second medical opinions is asking family, friends, or anyone who works in healthcare, which can be helpful, but not everyone has that sort of medical network to tap into. So this is for people that maybe don't have that. We also talk about a second medical opinion insurance coverage, and we can encourage everyone to check in with their health plan to see if they do cover the second medical opinion. So that's kind of like a summary of that page. And then why don't we look at the cancer surgery volume data that we've been talking about. So this is the data table that comes up. So we thought it would be helpful for patients to just select the cancer surgery they're interested in, because it's more likely that they have a specific cancer surgery. California and Pennsylvania provide the probably 11 most common cancer surgeries. So if we look at brain cancer, for example, you can see the top 10 volume centers for brain cancer for California and Pennsylvania. So UCSF is the leader with brain surgeries. And you could see in this NCI designation column, many of the high volume centers also happen to have NCI designation. So that's already, looking like, I'm not analyzing this, but it could be a predictor of high volumes or better outcomes, but it's not necessarily always the case. But I think it's helpful to put that there, and then patients can certainly look into those centers on their own. So this is kind of just a summary of what the data looks like. We invite anyone to, feel free to look into this or share this with anyone. And so that's the data table that we've embedded onto the site. And then we have a list of cancer.
Adam, if I could jump back in there. Yeah. And just want to, remind people of, this is, if you go to Pennsylvania's website, you're first presented with that PDF that I brought up for you, right? There's a whole lot of missingness in that, by which I mean, a bunch of blank cells that you necessarily don't want to look at, as well as some kind of user-friendly improvements we think we made is, say that you were already thinking about going to a specific hospital, then you can write in the search bar, look for that hospital. So say that, right, I want to look for Stanford Healthcare, it's already up there, or somewhere in UPMC, that works too. It'll filter, it'll find those for you. So then immediately for the hospital you're already considering, you can see their cancer surgeries, and that might give you a good idea as to how they're doing on these volumes compared to other people, and whether it might be a hospital that has this good predictor, as well as the county variable, right? So if you are looking for a hospital, some people only want to travel some certain distance. So if you're, say, in let's say San Mateo County in California, you can similarly type in San Mateo in there, and it will filter to just the hospitals that are in San Mateo. And then finally, you'll see something that also the PDFs and also the first version of our data table didn't have, is if you click on Stanford Healthcare there. So if you want to do that, then it'll take you to their website, in case you want to look into the hospital more, or able to, kind of find direct contact information. So those are a couple things that we've added, and just wanted to, note of, if you're someone kind of looking for how to use this, these are some features I think are important.
Yeah, thanks for sharing that, Nolan. So that's kind of the data table. We also have cancer resources. We do share the source files for the Pennsylvania and California data, as well as information about NCI, the American Cancer Society, some of the articles I referenced from our talk for patients, articles about second medical opinions, and then the book by Dr. Elisa Port. So that's basically the site. Let me come back to the slides, and Nolan, maybe do you want to wrap it up?
Yeah, and actually, Adam, if you could go back to that cancer resources pages one more time.
Sure.
And
yep,
the University of Michigan article, I think deep blue.
Oh yeah.
Mm-hmm. So one thing on here that is another kind of particularly potentially important proxy or metric that you can use when thinking about what might be a good hospital for going to get your cancer surgery at, is that another kind of important proxy, like I said, that we really haven't necessarily looked into or provided information for, but is one of the things that we're looking to do soon, is that Center for Medicare and Medicaid Services has this program called Hospital Compare. In this program, they essentially have a bunch of different quality metrics, which the hospitals that are under CMS, which can take Medicare, have to report to them. And in doing so, CMS then takes all these metrics, uses some sort of formula to assign every hospital a star rating. Some hospitals potentially might be ineligible for these, say if they didn't meet reporting requirements, or if there's some sort of underlying data integrity issue. But for the most part, the vast majority of hospitals that accept Medicare are going to have this star rating. And there's also some research that's been done more recently that shows that it's quite highly correlated, with cancer outcomes as well, just like surgical case volume is. So with that in mind, that's one example of kind of an improvement we think we can make, which we're just going to go over as our last slide.
All right.
So just to really reiterate and hammer home the point, we think the most important thing by far is always going to be opening this data, getting more data than just California and Pennsylvania, allowing patients to have data that they can look at when they're considering a particular hospital for their cancer surgery, as well as it being accessible to them, and just have this this relationship known about, right? Many people don't know about this relationship between cancer surgery volumes and outcomes. So we think that that's priority number one. Get more data, share this information, make sure that people know about it, because this is a potentially life-defining procedure that you might be about to go through. That being said, right, we are a group that started at Chi Hack Night. This is just a website that we put together, so have some further ideas for improvement. So as I mentioned, that you can filter by county, which might be a good way to find hospitals near you. But another thing we think that would be really useful is if we had a map view, so you could do more of a location-based search, right? You might be on the border of two counties, or you might want to be able to see the actual miles between yourself and a hospital you're looking at, without having to flip over to Google Maps. So Derek Eater, another TriHack Night superstar founder, right, has a little searchable map template that we've looked into using. Could be a big improvement. So that's the little picture up top right that he put together. I mentioned hospital compare star ratings, but there's a bunch of different, as I said, quality measures that go into that. So perhaps doing some digging there to see what cancer-specific measures go into that, or similar like complications measures, for example, could be really useful on CMS's QualityNet website to share those as well. And finally, honestly, we haven't done that much exploratory data analysis on this data that we have. So Adam mentioned a number of things of how other researchers have seen disparities in, for example, the number of cancer volume or number of surgery volumes that typical Black Indigenous person of color might have access to at their hospital versus a white person. So some of these, structural issues, it might be really interesting and important to see, do we see those same trends in the data that we have? Link up some data to, say, American Community Survey census data, and yeah, just really find how much of an effect might this discrepancy in access to high cancer surgery volume hospitals could be having. So those are some of the things on the top of our mind. That kind of concludes our presentation other than Q&A. Thank you all so much for having us. Really grateful both for having us and for being our starting place and where we did the vast majority of the creation of this website for.
So thank you, Adam. Thank you, Nolan. This was really great. So we will get ready to start the Q&A. We have about a little, maybe 15 minutes or so. And so just to remind everyone, you can submit your questions via the YouTube live chat. So type them there, and there will be a breakout group announcement after this. So in our post live stream Zoom. So feel free to stick around for that around 8 o'clock as well. But let's go ahead and get some questions going and some ideas flowing. So the first question for you all is, how are you currently doing outreach to inform patients and their families in the California or the Pennsylvania areas that this resource exists right now?
That's a very good question. We are just starting to really publicize the website. So I'm sorry, I've mentioned this to Nolan, but I do plan to reach out to patient advocacy groups, especially cancer advocacy groups in California and Pennsylvania, to promote the site, and then possibly reach out to other organizations as well to further promote the site. So that's something we are definitely thinking about. Nolan, any thoughts?
I think you definitely hit it, and I think potentially related, or one thing we didn't mention in terms of other than using FOIA to go about getting this data is one option we're certainly thinking about and could be useful is, contacting local and state representatives to advocate for this data being released as well, in addition to just, kind of linking up with patient advocacy organizations.
Okay, the next question. When it comes to health disparity in communities of color, have you connected with any organization that work on these issues about partnering to get that data / resource to help them inform the population they serve?
Yeah, so I think that's a really good point. Because we're just starting to publicize this, we haven't done that, but I think that is an excellent idea to make sure we reach out to organizations that address health disparities as a way to kind of get this information out there. So I think that is an excellent idea.
Okay, so I guess I know you've kind of mentioned this before already, but even just hearing it again, maybe someone could potentially have ideas or ways to help out, but kind of what are the next steps for Amulet Health? So, what are your outreach goals? What are your plans, and any updates on the FOIA requests that you've done so far?
I could speak to the FOIA request. We really haven't gone any further. We basically got rejected, And but we are definitely open to appealing those requests or sending requests to other states. We just need help with that. We don't have enough experience with navigating that side of things. So if there are any people that can help, we are certainly open to that. We are definitely now that we've kind of launched the website, which only happened in the past few months. We definitely want to make it public, publicize it on social media, and reach out to those advocacy organizations we discussed. So those are big next steps. And I think Nolan and I are talking about adding the hospital compare star rating to the data table. There is a public API for that, so we can kind of do it that way, or we can just get the data from Medicare.gov as well. Any other thoughts, Nolan?
Yeah, I think those are definitely the main ones. I think, like I mentioned, just for myself, kind of from a patient standpoint, other than having access to this data and knowing about it, I think really kind of moving to including a map view and a search that way, I think would be really intuitive just from a patient side, and definitely an improvement that I'd like to work on and see get done. Yeah, and also just Adam said, for if people have FOIA experience, et cetera, like once again, just huge shout out, thank you to Matt Chapman. I learned way more about FOIA than I could have ever wanted to know over a couple of hours. And also, based on the first couple of questions we've got, like, thank you all for further, improvement ideas and ways to go. As Adam says, this is definitely in its infancy. So yeah, we really appreciate questions of, have you done X yet? And it's like, we might not have thought of X. So yeah, just want to say thanks for these questions, fellow Tri-Hacknighters.
Okay, the next question is, what are the steps involved in getting this information for Illinois and other states? A timetable, you thinking sort of timeline, possibly?
So I'll use Illinois as an example. We FOIA'd the IDPH because we know there is a Illinois State Cancer Surgery Registry. So I think we did this pre-COVID, so it took, I think there's a certain amount of days they do have to get back to you. So it took probably a month or less to get the answer. But again, they have certain privacy sort of protections for keeping that data anonymized, and that doesn't help us. We need to know how many surgeries a hospital performed really to make that more meaningful. Having anonymized data doesn't really help us. So again, that's a further sort of, we would have to do some appealing, and we would need help from people with knowledge about FOIAs, and most likely attorneys. So it's like we kind of didn't go any further beyond Illinois because we thought we're going to run into these same roadblocks with other states, but who knows, that may not be the case. So it may be worth doing FOIAs for all of the other 47 states or so. So I think that's certainly something we could investigate. Again, any help with that would be much appreciated.
Yeah, I would say definitely that's something we've looked into. And sadly, one thing with that is you can't have a definite timetable or timeline with FOIA requests, right? You can get denied and for legal reasons never get that data. So, in Illinois' case, right, they had a very specific law, which meant that we couldn't get it, which certainly might not be the other case in other states. So, while we said, perhaps there was a little discouragement from Illinois, I think one of the kind of big things we could do, because obviously, as Adam mentioned, there's 47 other departments of public health at the state level. There's thousands and thousands of counties. It's just kind of some potential research into, if we can get any idea of which particular states or counties or, kind of organizations might be, most potentially willing to share this data or lenient in terms of protections that they have for, hospitals' confidentiality, I will say. Yeah, so just definitely want to make that note of, sadly, we can never give you a definite timeline about FOIAs, And also any sort of other ways that we can get the data. We've thought about hospitals like voluntarily reporting this as well, especially you might get hospitals that, for better or worse, have quite high cancer surgery volumes, being the ones that want to selectively report. But yeah, just those are some kind of thoughts on that, as well as there are other ways to go about this than just sending a whole bunch of different FOIAs, and potentially some ways that we can focus our FOIA requests, because that is definitely one of the big avenues. In addition to, like I said, trying to contact your local and state representatives.
Okay, so that makes a lot of sense. So do you know what percentage of patients actually seek a second opinion when it comes to choosing a surgeon or a hospital for cancer surgery?
Yeah, of the research I've read, it can be up to 50% of the time. There's not great data about it, but it is one of the most common reasons to seek a second medical opinion. So again, some of the data I've seen is up to 50% of the time a patient will seek a second medical opinion. So very common, and again, patients don't always have the information maybe needed to get that second medical opinion, and their insurance plan may not even cover that. So those are other barriers too. Everyone does not have the choice of going to another hospital that may be out of network. So we certainly advocate for states protecting the right to access a second medical opinion, and large employers who are health plans who administer claims, who pay for their employees' insurance. We certainly advocate for them to provide second medical opinion coverage as well. I don't know if Nolan wants to add anything to that.
Okay. Next question. Are there any hospital groups publishing this type of data individually on regular basis? If there was a national mandate for publishing data, what would something like FHIR, I don't know what that stands for, data standard help?
To our knowledge, there are no other organizations that publish this data. U.S. News and World Report is a ratings organization for hospitals. They do share cancer surgery volumes based on Medicare data for, I believe, colon cancer and one other form of cancer. So they do perform they do share some data about that. But to my knowledge, that's about the only organization that shares that kind of data, and it's still not comprehensive because it's only based on Medicare. So yeah, to my knowledge, I don't know of any other organizations that share this data, and I don't know if Nolan wants to add anything to that.
I think you've got me beat on all the medical questions, Adam.
So I think we have time for probably just one more question. So Epic is a big EHR player. So do you have any connections with working with their support teams or attending their conferences or even their user groups to see if any of their customers are publishing this data?
That's a good question. Epic is usually, all of the patient information that goes into Epic is very proprietary and protected under privacy laws. And those hospitals are likely protecting that data as well. More than likely, they're not really interested in sharing that data because it's very sensitive data. So to my knowledge, Epic isn't really working with hospitals or partnering with hospitals to share that data. That data certainly exists, but it's very protected due to patient privacy laws and also hospitals' interest in keeping their data private about certain things. So.
Just, I guess, a quick follow-up to that is, can you give like one reason or example as to why hospitals are so protective of that data? I know you mentioned patient privacy, which makes a lot of sense, but even beyond that, is there any type of reason that a hospital would try to keep that protected? What's kind of an incentive to do so?
Well, I guess cancer surgery volumes could be a good example of if a hospital performs lower volumes of cancer surgery, they may not want that information being out there and patients not going to their hospital because of that and losing revenue as a result. Many hospitals operate on very slim margins, so sometimes they can't afford to lose a big chunk of those patients. So this is a complicated issue, and we know hospitals are under a lot of stress and strain right now financially. But we do think this data is important, and I think there is a way to kind of to get it through maybe the government channels, maybe the FOIA channels, and if we can get enough of it out there, maybe it becomes commonplace, and maybe it's a move towards centralization with these kind of high risk type of surgeries where volumes do matter. So it's a start, and we'll see what happens.
Awesome. Well, that is all our questions, and it's 8 p.m., so it's perfect. So thank you, Adam. Thank you, Nolan. This has been a really great talk, and it's great to know that you all got your start at Shy Hack Night, so it feels even more special. So I think that is all we have for this evening. And as a reminder to everyone, we will have that post live stream Zoom, so feel free to follow the link so that way you can get access to that. And let's see, I think that's all I have. So I feel like before we leave, we have to say the special words. So Mieko, if you want to join me in doing so. So
Sure.
Without further ado, go forth
And
hack.
hack.
Great. Thank you, everyone. See you in
Night.
the live stream Zoom.
Thank you.